Welcome to this special Best of ECTRIMS short video. I'm John Strum, and just a few weeks ago, I was in Copenhagen, Denmark, attending ECTRIMS, the largest MS research conference in the world. Perhaps the most significant announcement made at ECTRIMS was the report from pharmaceutical manufacturer Sanofi of a successful outcome of the phase 3 clinical trial for an investigational disease-modifying therapy called Tolebrutinib. In this trial, Tolebrutinib was analyzed to determine its efficacy in delaying progression among people with non-active secondary progressive MS. As there are no currently approved treatments for secondary progressive MS, this was an important announcement. I had an opportunity to talk with Dr. Robert Fox, the principal investigator in that phase 3 clinical trial, and in a moment, you'll hear our conversation. Then you'll hear my conversation with Jennifer, someone who lives with MS, and you'll see and hear Jennifer's reaction to the news that Dr. Fox presented at ECTRIMS. This video presentation was made possible through a generous grant from Sanofi.
Dr. Robert Fox is a neurologist at the Cleveland Clinic's Mellon Center for Multiple Sclerosis Treatment and Research, as well as the Vice Chair of Research at the Cleveland Clinic Neurological Institute. Dr. Fox is also a professor of neurology at the Cleveland Clinic Lerner College of Medicine. He chairs the International Progressive MS Alliance Scientific Steering Committee, and Dr. Fox serves as the managing director of the NARCOMS Patient Registry. Dr. Fox is also the principal investigator in Hercules, the phase 3 clinical trial for Tolebrutinib, and he's at ECTRIMS to share the outcome of that clinical trial. Dr. Fox, can you explain what Tolebrutinib is?
So Tolebrutinib is one of the BTK inhibitors, or Bruton's tyrosine kinase inhibitors. This is a new class of therapies that are being evaluated in multiple sclerosis. And it works on an enzyme that we think, relevant to MS, downregulates and modulates B cells, particularly B cells in the periphery. But for the BTK inhibitors that can get into the central nervous system, it can also modulate microglia and macrophages, perhaps B cells that are in the central nervous system as well, but particularly microglia and macrophages, which we think are responsible for a compartmentalized inflammation or inflammation within the compartment of the central nervous system that we think drives some of the disability in multiple sclerosis.
And why is there real interest in this new category of DMTs, BTK inhibitors?
Yeah, so BTK inhibitors are exciting because it is a new way to modulate the immune system, a new way to change the immune response, hopefully to down-regulate the immune response and decrease inflammation in MS. And for the molecules that can get into the brain, not all BTK inhibitors can get into the brain. For the ones that can get into the brain at concentrations that are biologically active, we think it will also have some beneficial impact on the inflammation that resides within the brain and spinal cord.
And what was the Hercules clinical trial designed to evaluate?
So the Hercules trial is a phase 3 trial, meaning a licensing trial, that focused on patients with non-relapsing secondary progressive MS. So first, secondary progressive, that later stage of MS where disability or neurologic problems get worse little by little over time. And the non-relapsing prefix or modifier describes patients who have secondary progressive MS but are not having relapses. And indeed, the entry criteria for the trial was no relapses within the 2 years before entrance in the trial, although on average, these patients had more than 7 years without a clinical relapse. So we're quite quiescent in terms of the relapsing pathology, but still had the gradual little by little progression that we see so often in patients with secondary progressive MS.
What did you learn in this phase 3 trial?
Well, over 100 patients were randomized in a 2-to-1 ratio. So twice as many patients got oral Tolebrutinib once a day. The rest of the patients got a matching placebo, so a dummy pill. And patients were followed serially with neurologic exams and MRIs and safety monitoring for up to 3 years. And up to 3 years is a long time, but that's how long it takes to follow a large group of patients to see an impact on the proportion with progression of disability. And what we found, well, first, the primary outcome was 6-month confirmed disability progression. So what that means is progression of disability as measured by a standard disability scale, the Expanded Disability Status Scale, or EDSS, and it had to be confirmed 6 months later. Now, the reason for the confirmation is because neurologic performance can vary from day to day, and the assessors can vary how they assess the disability. So there ends up being a bit of variability and noise in measuring disability. So by requiring it to be confirmed 6 months later, we can feel more confident that this is true progression of the multiple sclerosis and not just part of the day-to-day variation that our patients will tell us about and we will see on exam. And what we found is the proportion of patients who had that 6-month confirmed sustained disability progression was reduced with Tolebrutinib and was reduced by 31% compared to those who were taking placebo. So they were 31% less likely to have the sustained progression of disability if they took Tolebrutinib than if they didn't. We also looked at the flip of this. We looked at improvement. So some of our patients do improve over time. And what we saw was a doubling of the proportion of patients with confirmed disability improvement. So looking at the same EDSS scale, looking for the same change, but looking at go the other way, improvement. 10% of patients on Tolebrutinib had an improvement in their disability that was confirmed 6 months later, compared to only 5% on placebo.
When you think about that outcome and you think about the typical course of disease for someone with secondary progressive MS, it's pretty remarkable.
Well, it is remarkable. And what excites me is now when I see patients in clinic who don't have any relapses, but are clearly getting worse little by little over time, and they say, what can I do to slow that? Up until now, I've really had to say, we really don't have something that will slow your progression. And it looks like now we do have something that will slow progression.
And with that encouraging news, what happens next?
So what happens next is that this will go to the regulators. And so the regulators will see this data set. They will also see the corresponding relapsing remit trial data set, the Gemini trials, and they will opine as to whether there is sufficient efficacy and a balance of efficacy and safety to merit this coming to general clinical practice.
Well, that's exciting.
It really is exciting. And now I'll mention two other things that are important to recognize. One is that the Gemini trials, so these are 2 relapsing remitting trials, although they did not show superiority in annualized relapse rate compared to an active alternative therapy, teriflunomide or Aubagio, it did show that patients treated with Tolebrutinib had a slowing of disability progression. So this confirmed what we found in the Hercules trial, that even though there was no reduction in the focal inflammation in the relapses with Tolebrutinib compared to a known approved drug, teriflunomide, there was a slowing of disability progression. So this is a second trial showing efficacy on disability progression to confirm what we found in Hercules. Now, it's important that we recognize there are some safety concerns that need to be appreciated with Tolebrutinib. There was an increase in respiratory infections, notably COVID-19 and nasopharyngitis, otherwise known as the common cold. They were seen a little bit more commonly in patients on Tolebrutinib than those taking placebo in the Hercules trial. There were also a small proportion of patients, 4% of patients, that had irritation of their liver. And we measure that by measuring liver enzymes. So 4% had an elevation of liver enzymes compared to about 1.5% of the placebo group. There was an even smaller proportion, 0.5%, to think about it, that as about 1 in 200 patients who had a very severe elevation in the liver enzymes, a very severe irritation of the liver. One of those patients unfortunately needed a liver transplant as a result of this irritation and then passed away shortly after getting the liver transplant. A reminder to us that these drugs do have some serious safety concerns. Now, since that case was recognized, more frequent monitoring was put into place to monitor patients for liver enzyme elevation, particularly in the first 90 days, because all the cases of very severe liver enzyme elevation was within the first 3 months. And so we think by instituting weekly liver enzyme monitoring for the first 3 months, we're hoping we can identify patients very quickly who have that irritation of the liver, and we can stop them from taking this drug and hopefully protect the liver. But nonetheless, there are some risks that need to be appreciated and balanced with the benefits we see on disability progression.
Well, Dr. Robert Fox, thanks for everything you do in the clinic, in the lab, to improve the lives of people who are living with MS. Thanks so much for talking with me.
Thanks for having me, John.
This conversation has been made possible through a generous grant from Sanofi.
You just watched my conversation at ECTRIMS with Dr. Robert Fox, and joining me to provide some perspective from someone who's living with MS is Jennifer. Thanks for joining me today, Jennifer.
Thanks for having me, John. I'm so happy to be invited.
So can you tell me when you were diagnosed with MS?
I was diagnosed in March of 2018. I had my first episode of optic neuritis in 1987, so I went undiagnosed for a long time.
I'm sorry to hear that.
That delay in treatment is probably why I'm secondary progressive now. So I am always interested in drugs about secondary progressive.
Well, we just heard Dr. Fox discussing the Hercules clinical trial, which focused on a potential disease-modifying therapy called Tolebrutinib and non-active secondary progressive MS. Tolebrutinib is part of a new category of DMTs called BTK inhibitors. Had you heard anything about Tolebrutinib or BTK inhibitors before?
I did do some research on BTK inhibitors because I heard there was a possibility that they might be able to reverse some damage, and I'm very interested in that. I have significant cognitive damage, but I had not heard of that one in particular before this interview.
BTK inhibitors block the activity of a protein that helps B cells develop. And it's already used to treat cancers that are caused by defective B cells. Now, other disease-modifying therapies have been shown to be effective in managing MS by targeting and destroying B cells. But this particular DMT can penetrate the blood-brain barrier. No other DMT can. Yeah. So this DMT can actually enter the central nervous system. What's your reaction?
That's so exciting that it can cross that blood-brain barrier to help people. I'm on Tolebrutinib, and I personally really like it, but even it can't cross that. So I'm very excited about these drugs. My first concern listening to the interview was the label inactive secondary progressive. The only way I could know if I'm inactive is if I go off to Tolebrutinib and have a relapse, and that's scary for me personally.
I can understand that. What the clinical trial did demonstrate was that Tolebrutinib significantly delayed the time to onset of disability worsening.
Yes.
What are your thoughts?
I would love to delay any disability worsening. I'm slowly getting worse, and I'm well aware of it, and so is my neurologist, and there's just nothing else out there that would help me. So it's going to be a decision of what is better, to try and delay progression or risk a relapse on my part, and that's something I'll have to decide with Dr. Thrower.
Now, one of the issues that Dr. Fox mentioned was that there was the risk of liver damage to a small number of clinical trial participants, which could mean that the FDA may approve Tolebrutinib but require monitoring for the first 90 days that someone is on it. So that could mean weekly visits to the clinic for the first 3 months. So given the potential benefit of this medication, is the juice worth the squeeze? Would you be okay with those?
I would be.
Clinic? Yes.
I would be. And my clinic is an hour and a half round trip. So I'm not popping 10 minutes down the road, but your liver is pretty important. So I would certainly agree to weekly monitoring, because if I could stop the progression, I would. I'd rather stop the progression knowing I wasn't going to have a relapse, but I would certainly consent to the monitoring, even though that's a lot every week.
Any other thoughts about this clinical trial that you'd care to share?
Well, in I'm interested in seeing if it's approved. I wish they had done it where you didn't have to be inactive, but I understand what they were doing and why they were doing it. So I'm on a wait and see approach at this moment. So, and we'll see what my doctor thinks. But thank God they're still working on it, and SPMS drugs don't come out that often. So I'm excited.
Well, we'll all be keeping a close watch on what happens next as Tolebrutinib makes its way through the regulatory process. Jennifer,
Yes.
thanks for sharing your thoughts with me today.
Thank you for having me. I hope you have a great day.
You too.